Welcome to Wellbeing Wednesdays with Arvind Narula on BW Wellbeing World. While we have been talking about mental health, but its conversation is limited to urban areas, metropolitan cities. To discuss this, on the Wellbeing Wednesdays, I have my guest, Raj Mariwala, who represents the new generation of philanthropists who are moving away from the traditional checkbook philanthropy of the earlier generation. Raj takes care of the Mariwala Health Initiatives as its director, where she's working towards a community based nationwide mental health ecosystem that is continually evolving and is accessible to the most marginalized segments of the society. Welcome to Wellbeing Wednesdays, Raj. It's such a pleasure to have you with us. The reason I was very keen to have this conversation is that, we've been talking about mental health for a decade now. But the conversations have always remained towards the metropolitan cities and the large towns, cities, etc. And we haven't gone beyond that. And what you do at Mariwala Health Initiatives is talking about the marginalized society. And so, which is why, this is of very high interest to me. And what I want to know is, how do you think has the concept of mental wellness developed both in urban areas and rural areas? Has the concept or the definition of mental wellness changed in the last few years?
Uh, Thank you so much for having me on here. And also, I think I'm just very glad that your series chooses to spotlight mental health. I think just having conversations around mental health is important. But of course, as you rightly pointed out, for far too long, our conversations on mental health have been too narrow, either restricted to urban or English speaking. So, in that sense, to answer your question, I do believe that there's been a change in how we talk about mental health. And just to give you an example, and this is not urban or rural, but when we were setting up Mariwala Health Initiative, we spoke to a bunch of people, and all of them told us start an organization, but don't put mental health in the title, in the name of your organization, because the words itself have a negative connotation. Now, this was in 2015. I'm happy to say that things have changed and mental health does not carry, I think, the same connotations anymore. And I think partly that is due to a lot of awareness building that has been done, especially in India. I think the first game changer was Deepika Padukone talking about it. And after that, now, I would say the second big change came in India as well as outside of India around COVID, where people suddenly started talking about mental health and saying that, this is important, this is something that's affecting all of us. So I think conversations have changed. People are more willing to talk about it. What hasn't changed, however, is that the conversation is being had only about certain types of people, only about certain types of users. And then there are, I think, myths that exist about who understands mental health, who doesn't understand mental health. People will say that in rural areas, the people who live there don't understand mental health, which I think is a somewhat simplistic way to look at it, for a couple of reasons. One is, I think everyone understands distress and what distress is. The second is that we don't always need to look at mental health from the lens of the purely biomedical, which is diagnosable conditions for which one needs to see a psychiatrist. But we all know during COVID, what happened to migrant communities, for example. We all knew that there was a very large amount of distress, right? So I think this is something that we really need to think about carefully, because in the places in this country where the DMHP is running, which is the District Mental Health Program, or where there's a psychiatrist sitting in district hospitals, there are likely to be people visiting for mental health care. There are, not to mention, definite issues with access to information, access with who and where and how to get help. And I mean, that's on the system to solve. But even if I take a look at it historically, in rural communities, in marginalized communities, people have always understood this. They may not have used terms that are easily translatable or understandable in English as we understand mental health, but people do go, to faith-based institutions, etc., to, I think, maybe get relief or to talk about suffering, whether or not that is evidence based, whether or not that is a good quote unquote solution, that's a separate matter entirely. But I do feel the awareness exists, and as much as the awareness exists, of course, as in urban spaces, discrimination against those with mental illness remains.
So, Raj, before I go into the rural aspect
Mm-hmm.
and what you at MHI are doing,
Mm-hmm.
what I want to understand is since you are dealing with mental health every day as a part of the initiative, do you think that people have started accessing mental well being uh, beyond, uh, like you said, biomedical? You know, so because one of the biggest, there are two challenges that I have observed in the past. One, it was
Mm-hmm.
always considered to be a taboo because mental health always was related with being mentally challenged, you know. And second aspect is that it was a taboo because you felt that what even the family would not support you and the issues were not recognizable, right? So, do you think that aspect has changed? And people, rather than, because in urban areas, people are talking about becoming a better version of themselves. So, you don't have to be unwell. I speak with a lot of healthcare providers, and we are talking of that shift that healthcare is not about hospitals where you go when you're unwell, but you take care of your health, and that is what healthcare stands for. Is it true for mental health as well?
I think in more privileged pockets, certainly. And I think with younger, urban English speaking people, for sure, people will, talk about going to therapy or why it's important for them to go to therapy. I personally, as well, do access therapy, and I have been accessing therapy, for many years now. It's a separate thing that I do live with a mental illness or with a mental health concern. Um, but even if I did not, I would probably be accessing therapy. I would also be accessing psychiatry, which I do. I take psychiatric medication. But just therapy and psychiatry would not be enough for someone like me to feel, I guess, feel at peace, feel content. So there are things that one has to do, I think, beyond that. And of course, the more important thing here is that I have the privilege to do it. I have the resources at my wherewithal to access a range of supports and a range of different ways in which to pursue, I think, better mental health for myself. The, that remains, I think, for other urban privileged young people. I'll still say that that does exist, maybe older people in a family saying, why do you want to go to therapy, etc. All that still exists. But I would say for anyone, be it privileged or not privileged, rural or urban, it's very important, I think, to look at mental health beyond just talk therapy and psychiatry. And there are many ways in which to pursue it. And if I may, I'll kind of take off on this tangent and say, especially in India, mental health is a development issue because you face exclusion on the basis of mental health conditions or mental illness. It's very important to link people up then to the right resources beyond your talk therapy and psychiatry. And I can, go into that later, but I think I'll leave it there for now.
But you spoke about a very important issue in terms of considering it to be a developmental issue. But Raj, you mentioned that you are accessing therapy, you are also taking medication. What is most powerful is rather than us talking about it or anybody else talking about it, can you share how it has impacted you and made your life better, or what is that change that you find?
One is, I think, therapy and medication, of course, helps in day to day living. It helps in day to day interactions. It helps me to do what I need to do. But I think to take a step back, I don't think that, I mean, that would have been, I think, marginally useful unless I had not managed to change my environment. And what do I mean by that? I have an MBA, I've done whatever XYZ in terms of my education, right? And so technically, I should have continued in the field of marketing or gone fully into the corporate world. But because I had the privilege to do so, and because it was better for my mental health, I actually left the corporate world. And this is before I started working on mental health, by the way. And I started working with animals. I'm actually a trained canine and feline behaviorist. I professionally consult, and that is, my career, so as to speak. And doing that, getting out of like an office, a certain atmosphere, having to wear certain types of clothes and follow certain types of rules, I think really allowed me to, uh, I guess, pursue better mental health. And it is that way for a lot of people. It's not just talk therapy or psychiatry. Some environmental changes also may be necessary. Some support structures also are necessary. So I think, does that kind of answer your question?
It does. It does. But Raj, what would be very interesting to know is that most people are unable to understand that they need help. And what is also worrying is that even people around you do not understand that you may need help, right? How did you know that you could seek help and turn your life to be a better and more productive?
That's a tougher question. I mean, I think partly I was always interested in psychology. Um, and then I think friends, other people around me, feminism, and of course, I had access. Most importantly, I have the privilege of language, of class, of caste to be able to go out, read, find these resources, and be like, okay, maybe I need to talk to someone about this. Call up 3, 4 people in my social circles who would also know enough. So it is very much, I think, related to the sort of privileges that I have, that I'm able to get all of this. Change in environment for sure, but also to figure out that I need support, where to get the support, how to get the support, and also not to mention, as you rightly said, people may not know. Do people have the agency? I was very confident in the agency I had in accessing the support, in maybe saying that this is not okay for me, that is not okay for me, asking a psychiatrist, okay, tell me exactly what the side effects of this medicine are. I can't afford to be sleepy in the middle of the day, things like that. So I think enough privilege to be a self advocate is also very important.
Correct. So, Raj, what motivated you to work towards understanding the mental well-being or mental health needs of the rural society? What kind of triggered this thought in your mind?
So, I mean, like we were discussing just now about my accessing XYZ stuff. Uh, the fact is that despite living with a mental health condition and actually a learning disability as well, it took until I was 21 to get my learning disability diagnosis. Now that's pretty massive because I actually really suffered throughout school. And imagine if someone like me took until 21 to get that diagnosis, and post the diagnosis, I mean, what's magical? All I learned is different ways in which to deal with the disability or to deal with the learning disability, so that I can access or read what I need to read or do what I need to do. That's all that has happened, literally. But to have those tools was a game changer. And so, if someone like me could take so long to get that, what about everyone else? Rural communities, marginalized communities, LGBTQI communities. So, if it takes me that long, what about everyone else? So, that's kind of what spurred me. And the other thing is, really, I do believe that mental health is very much an intersectional and an intersectoral issue. I mean, we've already spoken about it now in terms of education. And I shared that, school was hard because I didn't know what it was. And then, of course, it was also hard simply because I was struggling. But I think the flip side is that people then just think that you're very dumb, right? Teachers, other students. So education is right there. There's so much more in terms of if we talk about farmer mental health, if we talk about the mental health of women who face gender based violence. So it's a very deeply, I think, interconnected issue. And that's why I was keen to look into it. But I think what spurred me into action truly was the fact that even with my level of privilege, if it takes so long, what about everyone else?
So, Raj, how big of an issue is mental health when it comes to rural area, and how is it different from what we see in the urban areas?
So, I mean, in terms of numbers, the numbers are massive, and I don't even know if there's any point in going into the millions, right? But I'll tell you this, in rural areas, if if one is facing distress, if one has a mental health condition, and anxiety and depression are, more frequently spoken about, or say schizophrenia, right? The idea that one will have to figure out where to go for help, maybe to a district hospital. Now, whether there's a psychiatrist sitting at the district hospital, you don't know. The very fact that someone may be at a district hospital, another entire kind of question mark. Again, people don't know. Then, if one has to access that, to take one whole day off from work, pay for the transport, then go there, maybe then, navigate a district hospital system, which you may or may not be able to speak the language that's spoken there. You may not be able to read what's on signboards, then actually access medication, then maybe pay for medication. So imagine that if there is someone who lives with a severe mental illness in a rural area, they may have to spend just 3,000, 4,000 out of pocket. And that's not even counting the money that they've lost to then find that mental health support, to access, to just live their life on a daily basis. I mean, that is massive. And in fact, just like a lot of other healthcare, it may push people further into poverty. Now, the other thing with, I think, rural mental health is this very interesting statistic that those who live with severe mental illness actually, and this is a more general statistic, die about 15 to 20 years earlier than the general population. And that's not from mental illness, that's from actually their physical illnesses having gone untreated. So, on the basis of a mental illness itself, one is excluded from so many other arenas of life. And then that is physical health, employment, education, maybe, and all this is then much worse in a rural area where there just, let's face it, there's not just enough resources, whether it's primary healthcare or secondary healthcare or education or livelihood options or livelihood support.
And how is your institution making mental health accessible to these marginalized societies?
So we do this in a few ways, and I think the primary way in which we do this is we provide funding and we work with partners who work on the ground in largely grassroots-based programs that either train peer support workers or train other community workers to provide a certain level of support in the communities that they live in. And then beyond that certain level of support, there are always linkages. Remember when I said that it's, very intersectoral, it's very intersectional. So to make sure that, okay, the person knows that here is the psychiatrist, we're going to make sure that this happens. Now that psychiatrist sitting there in a district hospital is also by law mandated to keep a list of medications that should be free to dispense. So making sure that that is in place. That's one section. The other thing is making sure the person has maybe a ration card, a bank account, and is able to access whatever welfare benefits they are, they are able to in terms of whatever their location is. So it's a variety of different linkages along with mental health support so that we ensure inclusion of those who are maybe undergoing distress or who live with a mental illness. And this is one type of program. We also have, we fund a couple of national helplines that answer calls. And again, a national helpline may answer a call from someone sitting in a smaller town who may be undergoing gender based violence. So they will be, while they will be given uh, counseling on a call by trained counselors. Okay, these are psychologists who answer the calls. 40 minutes about social workers, lawyers, and maybe a women's cell from the town that they're calling from. That, whenever you want to access these other services, whenever you want to access legal services, or whenever you want to access a social worker, these are the people you can access in your town. So these are the linkages very kind of important. And that's, I think, two ways in which we do that. I think the third way is really advocacy with government and other, maybe both central and state, in terms of providing support, in terms of what can the government do to abide by the laws that we have and the policies that we already have in place. By the way, our laws and policies are pretty comprehensive and pretty good. They just need to be implemented. And so how do you do that? How do you kind of, let's say, nudge different governments into providing that? We've signed MOUs with a couple of state governments in order to help through our partners. Sometimes, we've done trainings on the Mental Health Care Act for judges, for police, for lawyers. So these are important things for everyone to know, and people may not know them. Government, branches may not know these. So that's one other way in which to do this advocacy. And finally, we also provide training ourselves, capacity building courses on including mental health services wherever you are doing work. So I'll give you an example. We trained a labor union collective on providing mental health support for each other, or we work with Mahila Panchayats to train them to provide support for each other. So it's not necessary that one needs to always go to some mental health expert and specialist to do this work. How do you build capacity in a range of different institutions? Because if we go the expert route, we are going to fail. And this is very clear simply because India has the same number of psychiatrists as the UK. Okay. Now, our population and their population, there's a vast disparity, but also more importantly, the treatment gap in India. So the number of people who need services versus the psychiatrists, psychologists who are out there, that's about 80% in India. In the UK, it's about 40%. They have the same number of psychiatrists as us. The US has more psychiatrists than the whole world put together, and they still have a treatment gap of about 30%. So that's clearly not the way to go. It's very important to look at different models, because not everyone is going to jump up and go straight to a psychiatrist, and maybe not everyone also needs to go to a psychiatrist.
So, Raj, this is very interesting. I mean, what you were talking of. But when you're looking at rural areas, my assumption is, I could be wrong, but maybe you can help me understand this. You spoke about that, there are faith-based systems that they follow, and the socio-economic strata is different, the social structure is different.
Mhm.
For example, if somebody has some problem which they may not even understand, it is a mental health problem,
Mhm.
Jharpur ke paas jana and all those things. How do you handle this? How do you handle educating the people in the rural area that first there could be a more scientific way to understand what could be happening with the person? Like you just said, going to an expert may not be the preferred route. Forget
Yes.
about not having enough experts, but they may not even want to go. Second thing is, while you answer this, also have you found disparity in access for mental health when it comes to women as compared to men or children?
So that's a great question. And I think the most interesting model for me, and I love kind of exploring things through examples. is there is a model that exists in Gujarat, okay, called Davadua, where actually people who go to the shrine are able to access faith-based support, but the people who are sitting in the shrine, who are providing the support, are then also taught how to send people and refer people to the right services, etc. So I think it's important to go to where people are. If I put up like a psychiatry camp in a village, I highly doubt anyone will show up, but people will show up at the shrine, right? And so then how do we do this? It's possibly better to educate and provide the people who run the shrine or who are the priests at the shrine, whatever the different words are, to give them the tools in order to refer elsewhere. So the Dawa Dua program actually does this work, and I think, as far as I know, uh, even the state government of Gujarat provides guidance and monitoring for this particular program. So that's one thing. Now, the second thing, in terms of disparity of access, I think, like most things, yes, women will find it harder to access mental health support, in terms of, giving up caregiving responsibilities. If someone has to travel for half a day to go to the district hospital, and the woman has to maybe cook, clean, fetch water, is she going to be able to do that? So that exists. I think that kind of gender disparity exists for mental health, as it does, for the other kind of arenas of life as well. The converse also happens, unfortunately, where in India, quite a few women have been put into mental health hospitals and then have been abandoned there by their families. And that is also quite a frequent and unfortunately common occurrence here in India. And I would say for children's mental health, really, I think resources are even less available, and it is much harder. So, yeah.
Right. And Raj, I've also believed that you speak about the right-based approach towards mental health. Can you share your thoughts on that?
So, I think, we never talk about this when we talk about stigma in mental health or the negativity that kind of surrounds mental illness. And one is like the history, the legacy. Where did mental health come from? Right. And in India, it came because it was got by the British. The British established the first asylums here in India. Now, these asylums were put under the order of the top ranking policemen of that area. Police, not health. And where did these asylums come from? They came from Western Europe, and they were started there by entrepreneurs, actually, who decided to separate out those people who didn't fit into society's norms. So, who was put there? Women who were pregnant before marriage, people who had epilepsy, people who maybe were sex workers, people with learning disabilities, of course. And my favorite example to give in India is, especially in Britain, people who are vegetarian as well, right? So the history, the legacy of kind of mental health and mental illness is actually of a social hierarchy. It was used as a disciplining tool. Who are we going to remove from society and keep them and keep separate? So some of that legacy still exists in mental health today. And the whole idea is that people, of course, are not fit to be in society. The first big reformation of mental health came from a treatment called, I think, the moral approach, where they taught people how to sit, how to behave, good manners, so as to speak, right, rather than actual health based stuff. And so it may surprise you to know that mental health, so as to speak, of psychiatry are actually based back when on the observations of those entrepreneurs from years ago who wrote about the pregnant women, people with epilepsy who were in the asylums at that time. And unfortunately, we still have that legacy today, chaining, mistreatment. And of course, this whole system was in two spaces. One was the asylum, and the other people, some other people were put into jails. And that was called jails for the criminally insane. So that is the kind of legacy that we have. And so it's not surprising, unfortunately, that human rights abuses continue to this day, and not just in India, world over. That's why I think I had mentioned earlier, I have the privilege of agency to say, this is what I want, this is what I don't want. And unfortunately, it is used here in India to, also put women who are not conforming. And there are enough and more cases that have been argued in the legal sphere, as well as cases that we know from our work here, where women have just been put in by their families in collusion with the doctors at the institution. So, rights based work is important in terms of just conditions in an asylum, who has to stay there, for how long you're forced to stay there. Maybe you don't step out ever, maybe you don't get a visitor, but also from the larger perspective of the fact that those who live with mental illnesses have a right to family, have a right to a job, have a right to community life, have a right to be part of society. And so that's where that comes from. And there are quite a few international laws around it, as well as Indian laws.
Raj, since we're talking about exclusion and inclusion, exclusion from the society based on choices, based on certain mental health issues which may not be understood correctly.
Right.
How do you deal with challenges in creating mental health awareness of LGBTQ? Because these are the people who are least understood. Forget about rural. I mean, even in the urban areas, they're not really understood.
Correct.
But in rural areas, it is even worse because they get excluded. People do not understand the choices, references, and usually it is linked to that something is wrong with them.
Correct. Which is yeah. Sorry. You were saying.
I said, how do we deal with this in the rural part of the country?
Correct. So, I mean, you are absolutely right. I think LGBTQ communities in the country face exclusion at multiple levels, and of course, it's linked to there's something wrong with you. Now, of course, historically, we have communities in India that have existed for years, Hijra community, right? And how does modern life look at the Hijra community? How does rural life look at LGBTQ folks? Exclusion levels are high, but what are some of the ways that we are working on to do better at this? Of course, in the community-based programs that we fund or that we partner on, there are facets that are taught in terms of training for community workers. And part of that, again, is very important, that yes, we can provide mental health support, but as important to link that person to LGBTQ community organizations themselves. It's not enough to provide mental health support. The other way that which we do it is we actually support LGBTQ community organizations to do mental health work, and quite a few of these are not urban. You'll be surprised to know. So LGBTQ communities in India, whether urban or rural, actually have been doing a massive amount of work, mental health and based on exclusion, for many years before formal mental health entered the scene. Because formal mental health entered the scene only after Section 377 was read down, I think about 5 years ago or something. So LGBTQ communities in that sense have been managing on their own for very long, due to strength of community building. And I think that is actually true for a lot of our communities in India, a lot of marginalized communities in India. The power of community organizing is quite something else. So that's one way in which to do it, actually, to support LGBTQ community-based organizations. I think the second thing that we do is we have developed a course called the Queer Affirmative Counseling Practices course, which was developed by LGBTQ mental health professionals themselves. Now, this is a course that is open for psychiatrists, psychologists. We've trained about 540 people, 540 mental health professionals in India to date in that course. And the idea is then that you are able to do queer affirmative work. And we took a very clear stance that we would actually try to get more and more people who practice mental health, who do their mental health practice in smaller towns and cities that are apart from the top four cities. And so that's worked somewhat for sure. 540 people have taken the course. And I think that has brought about a change, because the other change is, of course, legal change. So we do ask mental health professionals to advocate for LGBTQ communities. And that happened, I think, about 2 years ago. There was a very progressive judgment from the Madras High Court. And partly the statement was progressive because two queer affirmative counseling professionals who had been trained in this program went, spoke to the judge and oriented the judge on some of the issues and the stressors faced by LGBTQ communities. So I think work has to be done on both ends, from the community end, but also from the maybe advocacy end, where we are pushing systems improvements, changes in laws and policies, and maybe, in schools, etc. So, yeah.
So, Raj, I have read a little bit about this course, and I've also read where you've written about, you use the terms queer friendly and queer affirmative. How do you
Yes.
define these two terms so that we can differentiate between the two and understand better?
Right. So queer friendly has been around for a very long time, and all queer friendly says is that we treat everyone the same. Everyone who walks through the door is the same. So if you're queer, I'm queer friendly. It doesn't impact my practice at all. It doesn't impact the ways in which I will support you. Queer affirmative means I have taken the time, and I do take the time to continuously learn from the lived experiences of queer trans people and modify my practice to provide you better support. Now, if I say, if someone comes in, and I'm not a mental health professional, so I can't answer this like a mental health professional, but I can give you an example. Someone may say, oh, you're having relationship problems with your girlfriend or boyfriend, to a queer client. Have you spoken to your parents about it? But of course, the parents may not know, because it's not something that you may tell the parents, or to not maybe think about the isolation that a queer or a trans person may face. A queer affirmative counselor, on the other hand, would make sure that that particular client will have the resources to connect to whatever LGBTQ community organizations are out there. Right. So I think that's the difference. And again, this goes back, I think, to the history of psychiatry, because up until very recently, of course, LGBT, let's say lesbian, gay, trans was all in psychiatry textbooks as deviant behaviors, right? So, has there been enough change in mental health curricula itself to approach this differently? And the answer is no, there hasn't been, because a lot of our mental health curricula is actually copy pasted from the West. And part of that is this change, and they've not learned to do things differently. I mean, if I have to speak it in a business sense, I would say that, did you speak to the target audience and learn exactly what's bothering them, what their need is? And the answer is no.
So, Raj, you know, I'm very intrigued by one more thing. So, I'm
Sure,
tempted to ask you this.
sure,
Since you
sure.
spoke about learning disability, your learning disability. Now, when I look at the affluent families, well-educated families, they understand conditions like ADHD, etc., and they're now willing to go seek help. You know,
Mm-hmm.
but
Mm-hmm.
ADHD or such kind of conditions as a concept or understanding of this kind of a concept is unheard of in rural areas. They don't even understand that this could be a condition. But the child is losing out on opportunities there to do something. I mean, some of these kids are actually extra smart and they're able to do certain things much better than anyone else. but they lose out on an opportunity because nobody understands this, and the child, of course, does not know anything about it, right? So, what is it that you think can be done to bring this change to the children of this country who are not privileged to be living in large metropolitan cities?
I think that's an excellent question. And, it's really unfortunate that not even those who are living in urban cities will be able to access. And here I'm saying urban, yes, but I know plenty of people whose kids are, I mean, who are not privileged, um, whose kids may be living with ADHD or developmental or learning disabilities, who are unable to access it even in urban spaces, right? And but it's been caught simply because our education systems are good enough to catch it in urban spaces. People are still running around trying to get the right types of support for their child. This much I know, even in urban spaces, but it's caught. So, in that type of a case, I would ask, what can we do to equip our education systems in rural areas better? And I also have an example to share with you. So, there's one of our partners who works in rural Darjeeling, actually does work in low income private schools. Now, that's a thing in Darjeeling where there are private schools meant for low income families, because a lot of it is tea garden area and there are enough workers within those tea garden areas. So there is a network of low income private schools in rural Darjeeling where our partner uh, trains, and the program is called Broadleaf, DLR Predna. The teachers are trained to pick up whatever a child may need. If a child has different types of needs, work with that child through the school day. So, not out of school, not something special, but work and adapt their teaching, work and adapt their support, but not stop there. Actually, talk to the parents and the rest of the community surrounding the child. It could be joint family, it could be others, also the principal, in order to come up with a plan for that particular child, whichever child may need it. And this is a program that has done incredibly well. We've seen it expand over the last, I would say, 4 to 5 years. And I do believe that there are innovative solutions out there. Again, the linkages are there for who may need a much greater level of support or medication. But the reality is that a whole lot more kids are being supported with, the different learning needs in these private low income schools. So there are models out there. There are exciting things, and we don't need necessarily psychiatrists to go in and solve it.
This is one topic we can go on and on, because one of the things that I have observed among people around me is more in terms of being in denial. I mean, as parents as well. I mean, the first question that people ask is that, I really don't want to label my child. Uh, so, they are fearing acknowledging the problem. So if you don't acknowledge and accept it, you will not take an action. So I think that's the
Absolutely.
fundamental change that we need to bring in. Uh, you know, and as I said, I mean, this is an endless conversation. But before I let you go, Raj, working on mental health, and especially beyond the metropolitan cities, is a very collaborative approach, because you can't be everywhere. And like we were discussing, that you can't have experts being there. So you have to work on the local ecosystem, enabling them, educating them, and enabling them to work as a part of the social inclusion to make
Yes.
the change. What is your vision in terms of supporting this in a collaborative approach with the local authorities, the government, and what is your vision for the times to come as MHI?
Okay, that's a slightly harder question, but one is, I know that, at the level of scale that one has to reach, I really do believe that government needs to take this up at a much bigger scale, a much larger footing, and take it up persistently. So that's one, because no one is going to reach the scale that the government is going to reach. But I think for me, and I've said this quite often, that we really need to think about enlarging our definitions of mental health. We really need to maybe talk about distress that people are facing. And again, I'll give you an example. In 2021, I think Azim Premji University did a study that I think 230 million Indians were being pushed into poverty. Now, this also results in food insecurity. Now, food insecurity has, I think, a number of mental health concerns attached to it. There's unrelenting shame, anxiety, guilt, depression. Now, once that happens, there's also a linkage to homelessness and then to poverty. Now, the linkage is interesting because the moment you are homeless or you experience multidimensional poverty, your chances of living with a mental illness jump up threefold. And it's bidirectional. If you have a mental illness, your chances of becoming homeless or multidimensionally poor also, it's bidirectional, right? So, what are the ways in which we can enlarge, especially in India, the idea of mental health as a development issue? What are the innovative ways in which we can look at doing some preventive mental health work? So, yeah, I was saying that there are some innovative instruments out there, and I do believe that if we enlarge definitions, if we look at mental health intersectorally and as a development issue, I think we would be able to cover a whole lot more ground, as well as hopefully engage constructively with the stigma that surrounds mental health.
Raj, this has been such a wonderful conversation, and actually, I've been speaking to a lot of people around mind, body, soul, mental health, etc. But understanding the concept of distress and going beyond biomedical relative to the mental health understanding was really, really an eye opening for me. And also, what I have, it has kind of strengthened my belief that it has to be more related to becoming a better version of yourself, and you don't have to seek help just when you have mental challenges.
Yes.
And another thing is that what it really opened up for me, that we understanding that we are all human beings,
Yes. Yes.
irrespective of whether we live in the urban area or in the rural area. We do have challenges related to anxiety, depression, etc. But what could be leading to anxiety, depression, etc., the reasons could be very, very different because of the
Absolutely.
social structures that we live in. So,
Absolutely.
and which is why understanding how you create an environment in which mental health is not just accessible, but are willing to accept it. So it's not just creating access, but the ability to receive that help is is
Yes.
is a bigger issue, and which is where you need to start thinking out of the box and go beyond the experts and start looking at the local social structures and the people who the local population have faith in, trust in, to get
Yes.
them involved, educated and involved to impart this. So, and needless to say, one of the things that came into my mind is I was just imagining that we keep talking of the impact of creating a happier, joyful population. But if the largest part of our population is living in tier two, tier three, and rural parts of the country, imagine the kind of economic growth that we could see if we were to go and create that impact in these areas. So, thank you so much for sharing your thoughts with us. It's been a really, really, honestly, a very beautiful conversation. I really enjoyed it. I hope you did too.
Yes, it was absolutely lovely chatting with you. I mean, I think, as you said, we could have gone on easily for hours. So, yeah, it was absolutely wonderful. I think engaging, and you asked me, I think, such a wide range of questions we've managed to cover in a short time. So, very enjoyable conversation. Thank you.
Thank you.